Good afternoon, everybody. At the outset, I would like to thank the organizers of WBE Annual Conference EasyCode 2025 for having me here in this live inbox case presentations. I would discuss two cases here today, based mostly on right ventricular quantification, pulmonary hypertension assessment, as well as quantification of tricuspid regurgitation. Let's begin with case number 1. This was a male aged 33 years who came with chief complaints of dyspnea, NYHA class 2 and cough for 5 days, pain right cuff for 4 days. He had a past history of DVD left leg in July 2023. He is a smoker. After detection of that DVT in July 2023, he was on Eliquis, which he stopped on his own without doctor's permission. On examination, his heart rate was 116 per minute, BP was 114/80, height was 176, weight 76 kg with a BMI of 24.54. The systemic examination revealed raised JVP, but there was no pedal edema, right ventricular S3 was present, liver and spleen were non-palpable. This is the parasternal long axis view of the subject, where you can see there is an obviously dilated right ventricle, and in the color, this is color coded parasternal long axis once more. This M mode of aortic valve left atrium was taken not for any quantification, which has become obsolete now. I just kept this slide to show that you can see some of the aortic valve systolic spectrum is not the box shaped as we usually get in normal subjects. It kind of tapering down towards the end systole. This is perhaps because of compromise in left ventricular contractility or left ventricular ejection at the later phase of the systole, subject to the disease the patient has come in with. This parasternal, this M mode of LV-RV cavity for parasternal long axis has been shown again not for any quantification, but to give you an idea that the RV is more dilated than it is usually, which is better appreciated in this parasternal short axis view, where you can feel that the left ventricle is not the circular as it usually in these views. RV is obviously very dilated and the left ventricle is kind of D-shaped in systole, which suggests pressure overload of the right ventricle. The short axis at the great vessel level, this has been taken. Pulmonary artery appears mildly dilated, not significantly. There is some suspicion of a shadow in the right pulmonary artery, but this doesn't definitely qualify as a clot. The parasternal short axis, same with the color code, shows a rather clear right pulmonary artery branch, but sometimes there is a little bit of whitish shadow which is suspicious but not confirmatory of any clot. The right ventricular systolic function is compromised with a TAPSE of 11.6. This is the RV focused apical fourth chamber view, which again shows a dilated RV and RA. Another view of that, this picture has been taken for you to appreciate that what we call McConnell sign. McConnell sign is a sign which is pathognomonic of pulmonary embolism. It has a very high specificity, above 90%, but a rather low sensitivity. What is McConnell sign? There is a mid-free wall of the RV is akinetic or severely hypokinetic, while the RV apex shows normal or hypokinetic contraction. This is often due to tethering to the LV and mechanical support RV getting from it. Here you can appreciate the McConnell sign better. As you can see in the upper part, then the RV apex is moving well, where the RV free wall in the mid and basal segment is definitely hypokinetic. Let's go on further with the case. This is the tricuspid valve S prime, lateral annulus S prime, again to show that it's about 8.8, so it shows once more that the RV systolic function is compromised. There was a TR, mild to moderate, with a peak TR velocity of 3.55 meters per second, corresponding with about 50 millimeters of mercury TR pressure gradient. Another view of the thing, this measurement is somewhere close to what we got the other time, about 48 millimeter of mercury. This was to measure the pulmonary acceleration time. In the next slide, I will tell you why we are doing this, but this obviously shows that the acceleration time is greatly shortened. There is something which is called a 60-60 sign, which again is pathognomonic of pulmonary embolism, acute pulmonary embolism. What is 60-60 sign? Where the pulmonary valve acceleration time is less than 60 milliseconds, and the TR derived RV systolic pressure is less than 60 millimeter of mercury. This sign again has a very high specificity but a low sensitivity. And in this same patient, you can see the IVC is dilated about 27 millimeters with reduced collapsibility, suggesting fluid overload. So the RV strain was also taken, which is again compromised. The global strain is 10.3 and the free wall strain is 7.5. So the final diagnosis of this patient was a deep vein thrombosis with pulmonary hypertension, RV dysfunction, suggestive of acute pulmonary thromboembolism. We couldn't do any further investigation on the patient because the patient was immediately rushed to a hospital for further management. He is young, 33-year-old, otherwise fit, so saving his life was a priority here. He was admitted to medical super specialty hospital, where they did a peripheral venous Doppler of both lower limbs, which showed a right-sided DVT with partial canalization, and the thrombus was seen extending into the short saphenous vein. This is his discharge diagnosis of a submassive pulmonary embolism and recurrent deep vein thrombosis. They had done the CTPA to confirm the diagnosis, which had revealed nearly completely occluding thrombus involving the lower distal aspect of the right and left branch of the pulmonary arteries. So it was a bilateral thromboembolism. And the patient was treated with TPA, alteplase, and he did well, and he was discharged in a relatively stable condition after a few days. And he was advised to take Eliquis for indefinite period till it was stopped by the doctor. Now, this case was a case of pulmonary embolism. I am going to another spectrum of right ventricular pathologies, where this was a 24-year young girl. She came to a friend of mine with acute dyspnea and was referred to me for doing the echocardiography. Unfortunately, the video slides of this subject is not running, so I have to do with the still images only. This is a parasternal long axis view. Now I will go to the second case, which is another spectrum of right heart pathology. This was a young girl, 24-year-old, acutely dyspneic, had a fever, had come to a friend of mine for evaluation, who subsequently referred her to me for doing the echocardiography. Unfortunately, in this case, the video files are not running, so I have to do with the still images only, which is a gross compromise, but I hope you will accept it. The parasternal short long axis view shows a greatly dilated right ventricle. The right ventricular hypertrophy is not well appreciated in this view. The M mode, again like in the previous case of the aortic valve, shows partial closure of the valve towards the later part of systole, suggesting compromised left ventricular function. The M mode at the chordae level shows a obviously dilated right ventricle with some suspicion of a right ventricular free wall hypertrophy. The short axis view shows a D-shaped left ventricle, suggesting gross overload, and this was a volume and pressure overload both of the right ventricle. The pulmonary artery appears dilated, though it doesn't satisfy the criteria, but a young girl, 24-year-old, thin and lean, 24 millimeter of diameter of pulmonary artery, I would call it a dilated pulmonary artery. This is the 4-chamber RV focused view, which again shows a grossly dilated right ventricle and right atrium and kind of compressed left heart. The M mode at the pulmonary valve shows short pulmonary acceleration time, suggesting pulmonary hypertension. The right ventricular systolic function was compromised with TAPSE of 11 millimeters. And one more shot of the RV focused 4-chamber view. The patient has a florid TR with a TR gradient of TR velocity or maximum velocity of 5.04 meters per second, corresponding to a maximum PG of 101 millimeter mercury, and the mean PG came out to be 57. So she has a severe pulmonary hypertension. The inferior vena cava is again dilated and with very poor collapse with respiration. So, since I have little time in hand, I would like to appraise the audience of the new guidelines of pulmonary hypertension which came out in March this year. Some special points for the young people or the new echocardiographers in this hall. This is not meant for the people who are sitting on the front row. We calculate pulmonary artery pressure from the peak TR velocity, as you all know. But what is the jet is characterized by a dense envelope. This is what we should take when we do the TR velocity. The peak TR velocity suggestive of pulmonary hypertension in the new guidelines is if it is above 2.9 meters per second, corresponding to RA-RV gradient of 34, or if the peak TR velocity is above 2.8 meters per second, with at least two of the following echocardiographic indirect signs like RV enlargement, any two of these, RV enlargement, abnormal left ventricular eccentricity index, mid-systolic notching of the RV signal, mid-diastolic PR velocity exceeding 2.2 and signs of elevated RAP. This is the reason why the TR velocity is often we misread, because we have to measure the height of the TR velocity properly. We have to rather measure the beard, not the chin. The main cause of overestimating TR velocity is rich imagination, as it's shown in the left slide, or an overgain signal, both of which kind of give an excessive TR gradient. Common sources of AR become TR assessment is insufficient TR signal, where it can be either in underestimation as well as overestimation, or if the angle is over 40 degrees, it should be as parallel to the TR jet as possible. If it exceeds 40 degrees, it leads to 20 degrees, it leads to underestimation. And other common source is abnormal triangular TR jet, which is a severe TR, and this can lead to underestimation as well. Pulmonary artery end diastolic pressure is measured from the PR end diastolic velocity, as you all know, and the mean velocity is measured from the ideal way of measuring the mean velocity is if you can get the TR signal properly, as we measure the mean systolic blood pressure, 1/3 of the systolic pressure plus 2/3 of the diastolic pressure gives the. And now, according to the guidelines, the diagnosis of pH has changed, the definition has changed. It has been brought down to MAP above 20 millimeters of mercury from the 25 millimeters of mercury, which was earlier there. And the mean TR velocity, mean pulmonary artery pressure can be calculated by many of these formulae, but these are all indirect signs, so always not very reliable. And one thing we must start doing regularly is measuring the pulmonary vascular resistance by this Abbas's formula, which is very simple. PVR is peak TR velocity divided by VTI of the RVOT. The American Society now recommends that VTI of the RVOT should be measured in every single case and reported. And the PVR and the pulmonary vascular resistance, if it exceeds 2 Wood units, it's considered abnormal. Why it is important? Along with it, we have to measure the pulmonary capillary wedge pressure, which is an indirect, which is equivalent to the left ventricular end diastolic pressure by the Niguez formula. And this is required to classify the pulmonary hypertension into precapillary, isolated postcapillary, or combined pre and postcapillary. These are all there in this guideline paper, which is available in the AAC website, which I would recommend all of our young colleagues to download and go through and keep it handy with them when they do this. Thank you very much for your kind attention.